Let's finish this off with diseases. All right. So, diseases are typically defined as being due to homeostatic imbalances. Basically, there's the body is no longer able to maintain its ideal operating zone. These can be due to a variety of different things. Some of these are going to be genetic. Now, when we're talking about muscles, one of these genetic diseases is Duchenne muscular dystrophy. Basically, what occurs is that you inherit the lack of it, what's referred to as a functional gene, and this particular gene is responsible for the formation of a protein known as dystrophin, and dystrophin is integral to maintaining the integrity of the sarcolemma, so the muscle fiber membrane. Onset of this genetic disorder is seen early in childhood, and because of the severe impact on the individual, unfortunately, those with Duchenne muscular dystrophy rarely live into adulthood. And this is going to attack all skeletal muscle, potentially smooth as well. Any place we find this protein. Myasthenia gravis is an autoimmune condition. So autoimmune conditions are when, for reasons we are still working on, the body stops identifying cells that do belong as belonging. And they will typically attack them in set patterns, and these patterns are given various disease names. This particular one is in response to myasthenia gravis, where your body, specifically the antibodies, attack the neuromuscular junction and bind to the acetylcholine receptors in clusters. These fibers are going to remove the receptors, causing the individual to become less and less sensitive to acetylcholine. This is going to cause issues wherever we find acetylcholine. Now, we're talking about acetylcholine when it comes to skeletal muscle, but you have acetylcholine receptors everywhere in your body, in all systems, not just muscle related. So this is going to cause things like drooping eyelids and double vision and difficulty swallowing, weakness of your limbs, and the reason you typically are not going to survive, respiratory failure, inability to breathe. This is actually typically seen most frequently in women between the ages of 20 and 40. That does not mean men cannot get it. We just see it far less frequently in them. This does not mean you cannot develop it under the age of 20 or over the age of 40. It's just seen far less. This is the most frequent presentation. How do we treat myasthenia gravis? We typically treat it with cholinesterase inhibitors, so enzyme inhibitors to increase the amount of acetylcholine in the synaptic clefts, increasing the chance that it can bind to a receptor that is still there, and it can continue to bind to the limited receptors that are there. This is not going to fix the problem. This is just going to slow it down. We can also remove the thymus. Removing the thymus removes decreases the formation of a particular white blood cell that's responsible for attacking. This is limited effectiveness. The reason for the limited effectiveness is the thymus does not. I'm trying to explain this without getting into the next unit's conversation. The thymus basically kind of goes defunct about the age of 20 to 25. So if you develop myasthenia gravis and you're 35 years old, removing your thymus is not going to do anything. We can also administer immunosuppressive agents. These are going to suppress the immune system. These are, in conjunction with cholinesterase inhibitors, are going to help drastically slow down the disease progression. Again, though, it's not a cure, but it also does leave you more susceptible to other diseases like tuberculosis, bronchitis, COVID, the flu, colds, pick a bacterial or viral-borne disease and you will be more susceptible to it. An image of those drooping eyes and the weakness in the eye movements. Now, far more common will be things like muscle strains, or otherwise called a muscle pull. Ideally, though, not a muscle tear. Now, muscle strains should not be confused with sprains. I don't want to go over, okay. Yeah, okay, I don't have that in here. So, muscle strains. Muscle strains are going to be the muscles and tendons. Now you hear some people call muscle sprains. That's not a thing. Sprains, if I sprain my ankle, that's involving the ligaments of the ankle. Can I also have a muscle strain at the same time as a sprain? Yes, because there are tendons that cross that joint and I can stretch them out. So you can have what we refer to as a sprain strain, and we typically will diagnose sprain strains if we're talking about muscle and joint dysfunction in the back. We can differentiate between if it's muscles or ligaments or both. Just some PTs, chiros, orthopedic surgeons are lazy and we just sprain strain. So just be aware of that. Some of it's laziness, some of it is we get paid more if we diagnose it as a sprain strain versus just a sprain or a strain. And some of it's not even that, it's just we're given very limited time with our patients, so we do the big testing, and we, okay, yep, that tells me it's this, so I'm just going to go with this type of thing. Is that ideal? Is it an excuse? No, but it is the reality. Now, muscle pulls are going to be far more drastic than strains. This is not simply a stretching. This is a very exaggerated stretching. Pulls are going to take longer than strains to heal. And then obviously tears are not good at all. We have actual ripping of the muscle. These are going to take far longer to heal and do need rest. A strain, a week, maybe 2. A lot of people will be back to whatever they were doing with, appropriate treatment. The appropriate treatment varies depending on what muscles we're talking about here. Pulls, you might need a month to 2 months to 3, maybe a few more. Tears, you could be looking at a year plus because you do not want to re-tear it. They could be torn so bad that they involve surgery, and we literally sew it back together. Shin splints, everybody who's, done running or walking after not really doing a lot of running or walking have had the joy of having shin splints. What are shin splints? Shin splints are also called medial tibial stress syndrome. And basically what happens is there is repeated trauma, because yes, walking and running is traumatic. It's good trauma though, in appropriate patterns and applications, but it is trauma. Lifting a glass of water is trauma. But it is repeated trauma to the muscle tissue that surrounds the tibia. These muscles in particular. And this repeated trauma is repeated trauma that these muscles are not used to. It could be the aggressiveness of the trauma. It could be the amount of the trauma. It could be the length. Some more combination thereof. So this is why I was picking on running specifically. You go from not running at all to suddenly deciding to go run 3 miles. You might be able to do it one day, but then you do it again the next day. And the next day, your shins are killing you. So you rest. But then the next day, they're still killing you. Yeah, you have shin splints, my friend. You can also develop this from walking. Let's say you don't typically walk a lot. Walk to and from your car, as needed, and then you decide to go to a Six Flags amusement park. and you are standing and walking up and down the park from the minute it opens until the minute it closes. That's a whole lot more walking than you normally do. That's a whole lot more repeated usage trauma of those muscles. Maybe you would normally wear sneakers for class and work because you're a nurse, and so you get to wear nice comfy shoes. And for whatever reason, you went to this amusement park and you decided to wear flip-flops. That's going to give you repeated trauma. So you can see how this is applicable. I've actually never understood that. I used to go to amusement parks a lot, spent way too much time there, and I could never understand people who wore flip-flops. You're on concrete, standing, walking all day long. And flip-flops do not protect your foot at all. There's no support, there's no cushion. I never understood it. Anywho, though. Now, for my respiratory therapist individuals, there are muscles in the chest cavity your instructors, your respiratory therapist instructors, want you to memorize. Do you need to memorize them for an exam? A couple of these, for me. For them, you need to know them all. So what are they? Sternocleidomastoid mastoid. If you turn your head, that muscle that pops out, as you turn your head, that's the SCM, sternocleidomastoid mastoid. Located underneath that is going to be your scalenes. Then on the inside of the rib cage, we're going to have our inspiratory intercostal muscles. And on the outside of the rib cage, we're going to have our expiratory intercostals. Moving down to the bottom of the rib cage, we're going to have the diaphragm. And then we're also going to have the external obliques connecting to the rib cage and the rectus abdominis. This is actually what it's pointing to. It says expiratory abdominals, but it's the rectus abdominis. Now, this does say, review the neuromuscular synapse. Do you want to make sure you know details about that? We will talk more about synapses in general with the nervous system. And remember, oxygen debt.